RECIST version 1.1 is to make ORR simple, and that is great, but not always. Welcome everybody. You have clicked in a series of teaching videos explaining clinical drug development in oncology. This time, we will explain the concept of RECIST criteria and put them in context. For this, we will discuss an article where RECIST criteria were used successfully in kidney cancer. But before that, you will hear about the limitations of RECIST criteria. My name is Johannes Wolf. This is recorded in April 2024. Oncology is the medical field where we treat cancer. In this context, we call response when a tumor gets smaller after we gave a drug. In the context of drug development in oncology, response is classified into CR, complete response, PR, partial response, SD, stable disease, and PD, progressive disease. If you have a patient that has multiple lesions, multiple tumors, metastases in her or his body, then these response classifications can become really complex. Before we had RECIST criteria, we had WHO criteria, and those took longer to create numbers and to come up with a classification. Then this paper was published. This happened in 2000, and the term response evaluation criteria in solid tumors was formed. Since then, it was updated, and now we are talking about RECIST version 1.1. RECIST version 1.1 was published by Eisenhower in 2029 in the European Journal of Cancer. You can find it on PubMed, click on it, and then you can buy it, pay for it. You can also get it for free. It is on the NCI website in the CTAP section. That is a government organization paid by our taxes. I have paid my taxes. I'm getting it there. I'm not paying twice. The paper is typically a paper you will have to read during your time in clinical development, often used as a reference for details over and over again. I had to read it again to make this video. The video, in contrast, gives you the context, why this is necessary and its limitations, those you won't find in the paper. So finish the video, read the paper. These are the principles of RECIST version 1.1 in a single slide, high level, but the most important things are all combined in here. Let's start with the first one. We are defining target lesions. And one of the important points of RECIST 1.1 is that we're restricting that to a maximal number of 5. And obviously you should have 1, but it can even work without 1 when you go with non-target lesions only. But in between 1 and 5, you often have to choose because many patients have more than 5 tumor lesions. Tumor lesions in this case mean primary tumor and metastases. If, for instance, there are 5 lesions in the liver, 1 lesion in the lung, 1 lesion in bone, you can't just take 5 of all 5 of the liver lesions. You're supposed to only take maximum 2 of each organ. Then you measure that. And this measurement is probably the most important simplification that RECIST 1.1 has done, so that this whole thing of RECIST response criteria became doable and simple. We are measuring in only 1 dimension. Tumors are 3-dimensional structures. They have a volume. And even if you want to simplify it and just go by cross-sectional areas, that's an area that has still 2 dimensions. But we're not doing 3, we're not doing 2, we are doing 1, a diameter. And because of that simplification, a lot of rules are necessary to make it somewhat meaningful. I'm not sure I really understand that this is necessary. When I was a young resident, I spent nights to measure tumors and surprise my professor in the next morning in rounds to tell him, well, this medulloblastoma was 5.5 milliliters before radiation, and after radiation, it is down to 1.1 milliliter. I can tell you, the first time I did this, his face was worth the night of work. But then he wanted it all the time, and then I understand now why RECIST 1.1 does it a lot simpler. It is a lot of work. What I don't understand is why this is still work, a lot of work today. In the meantime, we have invented MRIs, PETs, positron emission tomography. We can determine the volume of pretty much anything from a planet to an atom. We can pick out a face out of 1,000 people from a video camera, and we can measure the volume of a tumor on the most sophisticated images we have in medicine. I don't believe this. I think a normal radiology report should have a volume of the tumor with every single time, and it should be measured automatically so that the radiologist doesn't spend a ton of time on measuring it. Reality is that we don't have radiology reports like that, and that's why RECIST version 1.1 is still important for us. Because we do one dimensions, we have to explain which dimension to use. That wouldn't be necessary if we did area or volume. We take the largest diameter. At least it needs to be an easily measurable and easily reproducible diameter for each of the tumor lesions that are included in the assessment. For lymph nodes, the rule is to use the shortest. Then we add up those measurements and we come to the sum of the largest diameters for a time point. The image is repeated every 6 to 8 weeks, and when we repeat images and compare them, then we can determine if things grew or shrank. And there are two numbers that you need to remember: 30% decrease or 20% increase. So CR, complete remission, complete response, does not require any measurements. Everything is gone, that's CR. Everything that is a little bigger but is significantly smaller from before is PR. And there is a limit necessary between PR and SD, stable disease, and that's 30%. If it shrinks by less than 30%, we call it stable disease. If it shrinks 30% or more, we call it partial response. The comparator for this number is the baseline before treatment started. The other number to remember is 20% increase makes it PD, progressive disease. But here, the comparator is not necessarily the baseline. It is the smallest number ever measured. So for the first repeat image, for the first image on treatment, both of those clearly have the same comparator. It is the image before treatment. But if the tumor then shrinks, then PD changes its comparator to the smallest number ever measured, which is called nadir. So, for example, a tumor that has 10 milliliters shrinks down to 1 milliliter and then grows back to 3 milliliters. At the time point it is 3 milliliters, it is still a lot smaller than it was before, but it is PD, it is progressive disease, because it has grown from before. And that's where we have the 20%. There aren't just target lesions, there are also non-target lesions. Those are not to be measured. And therefore, you cannot classify them in PR and SD. They are only to be classified in CR. That means everything is gone. That's for target and for non-target lesions the same. And progressive disease means it is clearly bigger. For this, in the non-target lesions, we don't have a number. The two categories in between, stable disease and partial response, are collapsed to one, and it's called non-CR, non-PD. One more principle in RECIST, it is the confirmation of response. What this means in this context is that there is a follow-up image. So if something shrank and it is a PR or CR, then in at least some protocols, you want a further image to determine if it's really smaller and if it stayed smaller. Something that just shortly and then immediately grew back is often not considered clinically relevant enough to make it a response, and therefore is then not considered confirmed. Now, the question if you need confirmation or not is study specific. And the paper of RECIST version 1.1 gives you criteria when it should be done in which way, but for determining in each protocol, it still needs to be spelled out in the protocol. Those are the big principles of RECIST version 1.1, and if you understand those, you can actually go now, turn the video off. I'm going to give you more things that are very interesting, but you could go with this and with the paper as reference. In order to come to measurements, you need images or at least a way to do those measurements. RECIST 1.1 talks about the caliper. That's what this is. A caliper is used for skin lesions when you don't have images. It talks about CT, and that is the preferred method. And it talks a little bit about chest X-ray, but trust me, chest X-rays are outdated. Do not use those for response criteria anymore. A CT and an MRI look relatively similar on images. This is a cross-section through the abdomen. In CT, bone is white. This is a vertebra. This is a rib. And then there is, it is whiter when there was contrast given. You see this kidney here, that is with more contrast, or at a time point where you see it better. Then at this time, it's the same kidney though. This image comes out of the Eisenhower 2009 paper, the original RECIST version 1.1 paper. This image comes from the paper before. It shows here a lesion and how it changed and then where it needs to be measured. CT and X-rays use X-rays, so there is radiation going through the body, and some people don't like it. In Germany, there is a whole agency to make sure not too much radiation passes through bodies. And considering that many of our patients are terminal cancer patients, where the risk of what radiation can do is really not relevant. Sometimes you may think that those are overdoing it. Those people are overdoing it, protecting patients from radiation that is necessary. The radiation is really relatively small. MRI, magnetic resonance imaging, is the more modern method. It can make images like that and many other ways of images as well. Still for the abdomen and for the lung, often CTs are used. For the brain, it is more often MRI by now. If bone is white, you're likely looking at a CT. PET is positron emission tomography. That is a functional method, and what lights up depends on the tracer. The most commonly used tracer is glucose sugar, and it will then show which parts of the body use a lot of sugar, accumulate sugar. Tumors do that. So tumors light up in PET. So do some of the organs, such as kidney and brain. But PET is functional. So a big difference between the more anatomic methods, such as MRI and CT, versus PET, the functional image, is a dead lesion, a scar from a surgery where there was a tumor before, but now there is no tumor anymore, may still show as tissue that is a plus tissue and doesn't belong in CT, and it may show in MRI. But in PET, it will be cold. That's why these functional images are more and more used, at least as addition to the more anatomical images of CT and MRI. Response evaluations and descriptions can also be seen as a process in which information is condensed. It starts with an enormous information about a single patient at a single time point with many different types of lesions, and it ends with a single yes and no, the treatment has worked or not, but with many, many steps in between. The same words of CR, PR, SD, and PD are used at multiple steps, and it is important to understand at which step you are. Otherwise, there is a lot of confusion, comes up all the time. So let's go through this. We start with the images we showed in the previous slide. measure every single target, every single lesion, if it's a target lesion, and for the non-target lesions, describe the size. We do this for each time point, each patient, and each of the tumor lesions. From this, we condense the information of a time point to one number for the entire patient. Before, there were lesions, which were one was CR, one was PR, another one was CR again, but now we give put them all together for one patient at one time point. And we say at that time point, the patient was in PR. But there are multiple time points for each patient. The next step of condensing its information is to come to one classification for each person. That is called the best response. Now, there are multiple patients in a clinical trial. Next thing we do is combine all the information of the different patients for each treatment arm or cohort, if it's a dose escalation study. And we calculate the response rate, counting the number of patients that had the response divided by the total number of patients. And finally, we compare those numbers between the treatment arms and decide if the study was a success. So it's a big condensation of information ending in the end with a yes or no. As we're doing this, our documentation system changes. There are the radiology images in the beginning turning into radiology reports that then turn into the electronic medical records of the hospital, of the treating physician. Those are records meant to help the patient primarily. And they get translated into records that are meant to help primarily the clinical trial. Nowadays, those are the electronic data capture systems. From the electronic data capture systems, we then come to response rates, and those may be documented in an IDMC report, an independent data monitoring committee report, which looks independently what the response rates are and takes out all the subjectivity. Hopefully, that at least is the idea. And eventually, this ends in a clinical study report or a submission to the FDA. At the same time, the people change, the people that do that work. It starts with the radiologist, moves over to the clinical team, the nurses, the doctors that use, and the data managers that use the electronic medical records, the PI, and the data managers that put them into the electronic data capture system, the sponsor clinical scientists, data managers, and medical monitors that review the data capture system and turn them into response rates. The IDMC are independent specialists themselves, and then it moves on to the regulatory specialists, and finally the regulatory authority to look at how this all worked. It's important to know when you hear CR, are we talking about a single lesion? Are we talking about a time point response? Are we talking about a best response for a patient or a response rate? Then it is a percentage. RECIST version 1.1 Eisenhower 9. Here you see the original tables from the paper. The core of that publication is often considered table number 1. It describes how the information from multiple tumor lesions, various locations of tumors and metastases in the same patient's body are to put together, condensed to an information about one response category at one time point, the so-called time point response. You see this on the right side, and here we call this overall response. And here in the different other columns, you see target lesions, non-target lesions, and new lesions. It is a little bit complex to read it, at least when I read this the first time. I had to read it again first. So let me try to help you. This column is the easiest column. We can eliminate it in a second. New lesions. Whenever there is a new lesion, the entire response category for the entire patient is considered progressive disease, regardless if the target lesion is bigger or smaller, non-target lesion bigger or smaller. If there is a new lesion, a new place in the body where there is a metastasis, that is progressive disease. if any of the others are clearly growing. So if the target lesions are progressive disease or the non-target lesions are progressive disease, then also the entire body is considered to be progressive disease. This column we can now forget. Let's do the top line next. There is only one way to consider the entire patient time point response a CR, complete response, and that is there is nothing to be seen, no cancer visible anymore. The target lesions are in CR and the non-target lesions are in CR, and obviously there is no new lesions. Only that is considered complete response. If the target lesions are in CR, but the non-target lesions are not yet measurable, but or visible, not measurable, but visible, or they cannot be evaluated, then the entire body is considered PR. And similar, if the target lesion is only PR, is still something there. And among the non-target lesions, there is something there. It's not grown, or it's not evaluable, then also the entire body is considered PR, partial response. Anything in between where you have decent information is considered stable disease. So that's when the target lesion is stable disease, when the non-target lesion is visible there, but it's neither progressive nor CR, and there is no new target lesion. That is then called stable disease. And the final evaluation category is non-evaluable, and that is if you can't measure the target lesions, or there are no target lesions. The non-target lesions didn't give you anything. They're neither in CR nor they are in PD, or they cannot be evaluated. And there is no new lesion. Then this whole thing is considered non-evaluable, and you need to wait for the next time point to actually make some kind of a call. This is the main table. And if you understood this, you're almost done. The other tables in that paper here is an extra table that is on purpose made so small that you can't read it, which is the same thing as this one, just if there is no target lesion measurable in the entire body. There are some images, and these images are meant to show how important it is to do the image when you repeat it in the same way as it was done before. This example is a CT, so bone is white. It's a little higher than the previous CT here. This black thing, that's air, that's lung. And this big organ here is the liver. And you see within the liver all these whitish areas. Those are all metastases. And you can see them because the image was done really early after the contrast was injected, or during the injection and the infusion of the contrast. You see this thing, that's the aorta, a big blood vessel. It's totally white. It's full of contrast. The same image done a little later looks quite different. You see the aorta is not quite that white anymore, and the liver has totally changed. It looks like there is a lot less metastases in there. That is not true. That's the same patient, the same time point there. This liver has as many metastases as this one because it is the same liver. What they want to show you with this paper is, with this image, is that you have to do it at the same time point. Again, you have to do it in the same way. And obviously, if you compare a CT to an MRI to a CT, that doesn't work very well either. The table underneath, table 3 of that paper, deals with the question of how to put different time points together to define a best response for an individual patient. And that has also something to do with the confirmation. Remember, I said for confirmed CR, you need a second image to have, and it also show CR to call it a best overall response confirmed CR. And the same for PR, obviously. But that's only when they are the same. When they're different, then it gets easily complicated, and then you use this table to come to one category for each patient. Nothing is perfect. Now, after reading the paper and understanding all of it, now we're coming to the fun. Where is it not enough? Well, I put a couple of shortcomings together here. Please forgive the wonderful creators of RECIST Version 1.1. This is a fantastic and extremely important paper for clinical development, drug development. But It is even better if you know the shortcomings of that. So, first of all, this is for solid tumors. It's not for leukemia. In the paper, it says it's not for lymphoma or for brain tumors, although it can be used for this. Commonly for lymphoma, the Lugano criteria are used, and for brain tumors, the Raynaud criteria are used. Both of those use 2 dimensions as measurements. We talked about those shrinkage measurements. It is obvious that a shrinkage in percent as measured by RECIST does not reflect the reduction of the tumor load. Any number that is measured as described in RECIST is largely underestimating what has happened to the volume. You know, if you halven the diameter of a shape and the shape doesn't change, the volume of the shape was divided by 8. So don't mistake that as a clinical information. There are the biological clinical phenomena of pseudoprogression and pseudo-response. Those are not really represented in the RECIST version 1.1 publication. They come up a little bit. Let me explain what that is. Pseudoprogression came in my knowledge around first with temozolomide during radiation with glioblastoma. After that treatment, the tumors looked a little bigger, but then they started shrinking, and we started calling this pseudo-progression because that increase in the initial increase was an swelling, an influx of fluid, and possibly inflammatory cells. The same phenomenon became really common, really important, and well-known in science when we learned to harness the immune system with immuno-oncology. When the immune system is used to fight cancer, then there will be an influx of inflammatory cells, lymphocytes, neutrophils, into the tumor before the tumor cells die. These cells that kill the tumor cells need to come, and they have a volume too. If you do the image when they've just come in, the tumor looks bigger, and then it starts shrinking when the inflammatory cells kill the tumor cells. But this bigger in the beginning isn't caused by more tumor cells. It just is an influx of other elements. Something not quite as common is the pseudo-response. That came, for instance, around the anti-angiogenic drugs. Bevacizumab, for instance, causes blood vessels to obliterate, have less blood vessels. They are less leaky. It can happen that a tumor is hardly visible on a CT unless contrast is given, and then when contrast is given, it shows up white and bright and white and obvious. But when you treat that tumor, the blood vessels are treated, and then this contrast enhancement disappears. Now, ideally, the tumor cells also die from that, but they not always do that. Some tumors are less dependent on those blood vessels than we want them to be when we do anti-angiogenesis, and these tumor cells just keep infiltrating, or they are just at least happily stay where they are. But you don't see them anymore because the tumor isn't contrast enhancing anymore. The patient doesn't have a benefit for overall survival. Patients are often a little bit better when the swelling goes away, just because the swelling does symptoms as well, but it doesn't affect overall survival. That phenomenon is called pseudo-response. Neither of those two phenomena is really reflected in the simple method of RECIST 1.1. And if you are writing a protocol that either has a treatment known to do this, or pseudo-response, or a tumor known to commonly do this, you better take that into account when you define your response criteria and don't just use RECIST version 1.1. Similar, the concept of treatment beyond progression is really not addressed, and it needs to be addressed. That in the old times, that wasn't a problem. In the old times, the standard approach was you give treatment, the tumor shrinks, that's good. If the tumor grows again, then you stop the treatment and you do something else. Nowadays, that general simple schema has come under attack, and it turned out that there are a number of situations where treating beyond progression is good for the patients. That could be because the progression isn't progression and is pseudo-progression, but it can also be that the treatment accumulates. It can be that you keep using the same drug and add another drug, and then the tumor responds. All of those things don't get addressed if you call the entire disease progressive disease, call progression-free survival ended at that time. Yet it needs to be addressed if we want to get our arms around the result of treatment beyond progression. Then we need to have good response definitions, descriptions of happens in treatment of beyond progression, and RECIST version 1.1 really does not deliver that. In 2009, CT was the best method. Now, methods of images have improved. PET and MRI, or combinations, PET-CT, PET-MRI, various tracers in PET have come around, and those methods may be better to describe really what happens with a cancer on treatment, both with may be more sensitive to show progression, and they may be more accurate to show response. We continue learning, and as we continue learning, we also need to revise our criteria and adapt, and RECIST version 1.1 was the status of 2009. There's a paragraph in there about lesions falling apart. I have another slide of that. That is just off, and you'll see in a moment why I think that is the case. Here is the table, the famous table number 1 from the paper. I have just changed it. So I envision a patient that has non-target lesions and target lesions. I've done all my measurements. I've determined CR/PR. Now I want to determine the time point response. The way I like to do this is to have a 2-dimensional table. So I put here the target lesions, CR, PR, SD, PD, or non-evaluable, and the non-target lesions the same. And then I looked in the other table, the table I showed in the last slide, and filled it in. Some things are really simple. Whenever there is PD, may this be in the non-target lesion, or may this be in the target lesion, the entire time point response is PD. Also for CR, you remember, for CR, everything needs to be gone. The new non-target lesions need to be in CR, the target lesions need to be in CR, and there can't be a new lesion. Only then you can call the entire body time point response a CR. And then you can look at the others, and I think this is an easier way to show it. But when you do the table, you notice they missed one. This one is not described in the table I showed before, the original table. That would be the non-target lesion is in CR and the target lesion is in SD. What is that? I would call it SD. That's how I wrote this, but that is not from the table. That's just me making that up. Now, does that ever exist? Well, it is admittedly really rare, but it is not unheard of. It can happen. For instance, a non-target lesion may be peritoneal carcinomatosis. So the peritoneum is the inner skin of the abdomen that is around all the organs, and peritoneal carcinomatosis means that there are cancer cells all over there, but haven't made a solid lesion. They're kind of floating or sitting on the peritoneum and can't be measured. That is a normal example for a non-target lesion. It can be, for instance, there could be a relatively indolent disease that has a lung metastasis and has peritoneal carcinomatosis. The treating physicians do something about the peritoneal carcinomatosis and have to leave the lung lesion for a while alone. For instance, they could give chemotherapy in the peritoneum, intraperitoneal chemotherapy, or an abdominal bath by radiation, a very old thing that still sometimes is necessary to be done. And the peritoneal carcinomatosis could go away. That would be CR of the non-target lesion. At the same time, the lung lesion wasn't treated at all because the peritoneal carcinomatosis was local treatment. And let's assume this lesion didn't grow and didn't turn into PD. So at least not grow enough to make it PD. Then you have a category that is not described in the previous table. Please don't make the mistake to believe that RECIST, this very simple method, is enough for clinical care. For clinical care, you can't just measure a lesion and think you can make a decision. You have to look at the structure of the lesion, how it changes. There can be a necrosis inside of the lesion that could actually mean the tumor is responding, even though the measurements haven't changed. It is very important how the structures around the different tumors behave. You need to include a lot of further information, such as lab values, how the patient is doing, to come up with meaningful clinical decisions. RECIST version 1.1 is not for clinical care. That would be extremely sloppy to make a clinical care patient decision based on that minimal piece of information. And finally, it is also not enough for the protocols. RECIST 1.1 is a framework. It is an umbrella. You should not, when you write a protocol, just use RECIST version 1.1 for response criteria. Even within the paper, there are paragraphs that talk about when you should use confirmation of response and when you should not use confirmation of response. The diseases differ from each other. It's not enough to just say we're going to use version 1.1. If you want to write a protocol, take the paragraphs of the original paper, quote where you got it from, rewrite the pieces that need to be rewritten, and explain as well that this is not from the paper, but is specific for the protocol. And then you can call these things RECIST 1.1 adjusted to the treatment or modified by the treatment. There are many, many papers of various ways of adjusting and further developing RECIST version 1.1. Let me come to the last one. This is hard to just ignore. That is, in my opinion, really wrong. And I can't say this in any other way. That is scientifically wrong. It defies the rules of geometry. The only thing I can say is it will be really rare. And I'd rather like use the word of forgiveness, because of all these wonderful authors have put all these fantastic rules together. They are allowed to make a mistake. So here is the mistake. A lesion that splits. For a lesion that splits, they say measure each of the split lesions and count them together. So here's the example. I drew a lesion here of 3 centimeters, 1, 2, 3 centimeters, and it is conveniently really round and simple to measure. This lesion is treated, and then we have these 3 little pieces, and all in between is gone. That is clearly less tumor. But if you measure this, it is 1, 2, 3. And if you measure those, it's 1, 2, 3, and 4. It is an increase by 25% of the sum of largest diameters. That defines progressive disease. This lesion did not progress. This lesion shrank. And in contrast, as an other example, a little bit of increase here. This lesion here would have grown from 3 centimeters to 3.5 centimeters, and that would be called stable disease. So if you follow those guidelines, you'll have one patient that has this. Tumor falls apart because it's like the treatment kills the cancer cells, and we call that PD. And we have this, where the tumor grows, just not too much, and we call that stable disease. That is wrong. I'm just advising to not copy that paragraph when you are copying paragraphs out of RECIST 1.1 and find a different solution. It is a result of simplifying it. And maybe in this case, it was just simplifying it too much. It comes from the single diameter measurements. If those were measured in 2 diameters and you count them together as lymphoma people or brain tumor people do that, usually that problem would not occur. That's the problem of RECIST version 1.1. Let us all forgive the authors, because the RECIST version 1.1 is really, really important and has made a lot of progress possible in medical science drug development. Now that I showed you all these bad things, let me show you the good thing. We'll do this as a journal club. RECIST version 1.1 has made tremendous impact on clinical drug development in oncology. Here is one of the highlights, one of the biggest examples. I'm going to present this as a journal club. I'm presenting an article. The article I selected is from 2021, and it describes the use of belzutifan in renal cell carcinoma. Please let me tell you, belzutifan is made by Merck, and I have no connections to Merck. I am not receiving any money. However, for full disclosure, I am consulting for a clinical trial for an investigational agent, and belzutifan is one of the other drugs also used in the treatment protocol. Now, that would not make me pick a paper here. This is just because I find the story so tremendously interesting, and because the New England Journal of Medicine has published a study with an endpoint of response. Typically, this journal goes for phase 3 studies, gigantic randomized trials with time to event endpoints such as overall survival and progression-free survival, but not for this one. This trial was so prominent in result that it got published in the New England Journal of Medicine 2021. Here is the table that describes the overall outcome of these patients. And you see complete responses, none. Partial responses, 30 of 61. Stable disease, the other 30 of the 61. And then there was one patient non-evaluable because that patient didn't reach the second image, so they couldn't determine response. As denominator, they used the entire population, so they counted this patient. Otherwise, the response rate would have been 50%. It is 49%. That is a very, very high response rate for the disease population here. We'll talk a little bit about the spider plot in a moment, but before we do this, let me give you the background of renal cell carcinoma and belzutifan. Kidney cancer, clear cell renal cell carcinoma. Allow me one slide of medicine among all our drug development video. The kidney is there to produce urine, which excretes water-soluble toxins, urea and uric acid out of the blood into the ureter, the bladder, and is excreted. The kidney is also an endocrine organ, and it produces hormones such as erythropoietin, which results in producing more red blood cells. Kidney cancer may develop inside the kidney as a little thing, continue to grow inside the kidney. When it starts growing out of the kidney, it has the tendency to grow along the blood vessels, in particular the veins. This is the big blood vessel that leads the blood from the lower part of the body up to the heart, and from there it goes to the lungs. So this is non-oxygenated blood. It then picks up the oxygen in the lung and comes out of the heart, goes down to this blood vessel that's called the aorta, and it has oxygenated blood. Kidney cancers tend to grow into the vein. This is the inferior vena cava. And if the kidney cancer is that large, then it is really hard to treat. It is advanced disease. It continues to metastasize, and it can metastasize pretty much everywhere: lung, liver, brain, lymph nodes can metastasize all of these places. The cause of kidney cancer include Hippel-Lindau disease. That is a rare inherited disease, and the next slide will say a little bit more about it. There are more common risk factors such as smoking, obesity, and hypertension. Kidney cancers are common. 76,000 new kidney cancers in the US per year. This is less common than the most common cancers in women: breast cancer, and in men, prostate cancer, and both together lung cancer, but it comes right after. 30,800 deaths per year. 85% of the kidney cancer are renal cell carcinoma, and of those, 70% are clear cell renal cell carcinoma. The median age of diagnosis is 64 years. It is a disease of the elderly. The incidence is rising. It is becoming more common, and the death rate is falling. The treatment is more successful. The treatment, if you want to make it in a single line, is resection followed by drug combinations, and axitinib pembrolizumab is one of them. There are others. The resection is particularly relevant when the tumor is still small and not as large as this. And you can, by resecting the kidney, get rid of all of the cancer. There are other drug classes. Famously, prominently, if you look through the drug classes that help against kidney cancer, you are missing chemotherapy. As you know, chemotherapy was the beginning of oncology, and it helped in many diseases, is still a prominent part of standard of care in many cancers, and it helped more or less in some cancers. Kidney cancer is famous for it not helping much or not at all. In contrast, immuno-oncology celebrated its first successes in kidney cancer and melanoma, a few others, but kidney cancer were very prominent for first successes there. If you read through the drug classes that are by now used, you will find also HIF2a, belzutifan. This is what this paper is about that we're discussing. The overall prognosis is relatively good, considering this is cancer, if the disease is localized. Then more than 90% of patients will survive 5 years or longer. In contrast, when the disease is advanced, such as metastases or that type of tumor growth, then the prognosis is still pretty poor. Belzutifan and HIF2a. So HIF2a stands for hypoxia-inducible factor 2 alpha. Let's skip over how this comes about, where it comes from. It is a molecule inside the cell, and in case there is enough oxygen around in normoxia, the cell gets rid of it. The way it does that is hydroxylation, and then it binds to VHL, PVHL, that is von Hippel-Lindau tumor suppressor protein. That results in ubiquination, that is the labeling of a protein for proteasomal degradation, which is sort of the trash can for protein inside the cell. That's what happens in normoxia. The cell gets rid of HIF2a. In von Hippel-Lindau disease, patients cannot make VHL, and this runs all the time. That is the same as when the cell is in hypoxia, does not have enough oxygen around. The molecule aggregates, and that's a complicated thing, not just HIF2a involved. It moves to the nucleus and binds to hypoxia-responsive elements, which, through a couple of further steps, result in molecules made by the cells. Among those are VEGF, vascular endothelial cell growth factor, and EPO, erythropoietin. Vascular endothelial cell growth factor results in angiogenesis, in making new blood vessels. EPO results in erythropoiesis, making new red blood cells. Both of those result in a better oxygenation of the cell that had this poor hypoxia. And then hopefully this goes away and the cell is in normoxia and HIF2a is degraded. Kidney cancer, renal cell carcinoma occur in this disease, the renal cell cancer, apparently like HIF2a. And if you take it away from them by inhibiting it with belzutifan, then these cancer cells die. This is how this whole thing works. Let us come back to the paper now that we know all the background. In the methods, you will find how often the images are done, what images there were, and you see this was CT or MRI. And you will also find how the response criteria were applied. and which method was used. And what do we find here? RECIST version 1.1. What a lucky incidence in a video about RECIST version 1.1. This is a great success for this method of describing responses. But you also see there is a whole paragraph of more further definitions, explanations, how responses are defined. It isn't enough to just say I used version 1.1. You have to describe more, and the protocol has a lot more text than the paper has. Let's go one more time to the results. Spider plots. If ever a drug developer asks you what did the spider plot look like, this is what they mean. It is a line graph where every patient tumor or tumor load is represented by a line over time. And then multiple lines are put together. And if you have enough, it can look like a spider web. You see multiple things. One is one about the method. Spider plots really work only up to about 20 patients. If you have more than that, then it gets really chaotic like this is. But these authors wanted to make a point, and that's why they put all these graphs together. They labeled with colors those patients where there was eventually a confirmed partial response, and with green, and with blue, those where there was eventually stable disease as final count. And you see, this is the time point where the treatment started, and it is obvious that those with partial response are below those with stable disease. Well, that's by definition. The information of this figure is on the other side. It is the treatment, not the treatment, the growth of the tumors before the treatment started. And you see here also the green curves line up below the blue curves. What does that mean? The 0 is defined by starting point. So this is plus minus in percent. So it's got nothing to do with how big the tumor was at that time. It would in any case be called 0. The fact that the green ones are below the others mean they grew faster. So those tumors that grew faster were more sensitive to HIF2 alpha inhibition. Apparently, when they grow faster, they love their HIF2 alpha more, and if you inhibit, then the tumor shrinks more. That is an important point, and it shows that response isn't just all you learn from measuring tumors. The speed of growth before is also an important point. And the authors of the Belzutifan paper just added this piece of information to our knowledge on the sideline, in addition to bringing the drug to us. We're coming to the end of the video. This is the final proof that RECIST version 1.1 is a fantastic thing, and it can really make a big difference for a patient's life when it is used well. The Belzutifan approval. You know, most drugs get approved on time to event endpoints. Big randomized trials where progression-free survival is better when the drug is used than when it is not used, ideally with a placebo control. Very rarely, drugs can get approved without control group if the outcomes are so impressive. Response can result in drug approval if it is really, really impressive. That was the case here in Belzutifan, and they used RECIST version 1.1. Hooray! Great success. This is the approved, this taken from the label. The source of information is the FDA website. It was approved in 2021, and the indication is patients with von Hippel-Lindau disease, and here you see renal cell carcinoma. There are also other diseases coming with the same mechanism. Interesting also the adverse events. Yeah, under the warnings and precautions, you see anemia. How can that be? Well, remember, EPO, erythropoietin, is made in response to HIF2 alpha. if you inhibit HIF2 alpha, you may not have enough erythropoietin, and then you don't have enough red blood cells, and that is called anemia. And hypoxia, that means not enough oxygen in blood. Well, the whole thing with HIF2 alpha is a response to not having enough. Now, if you knock that mechanism out, it is kind of logical that you may run into hypoxia as a phenomenon in the whole body. Isn't this a beautiful example how mechanisms of action show effect and also explain the side effect? I think it's fantastic. The drug is approved in the US at the time point where we make this video, and it is approved in the UK. It is not approved yet in all of Europe. Let's see where that goes. It's also not approved in Japan, to my knowledge, in 2024. And if you made it up to this point in the video, I congratulate you. You are now really well informed about RECIST version 1.1. You know how to use the CT, how to compare it to an MRI, how to distinguish it from an MRI, how to measure in one dimension only to make it simple. That is the concept of RECIST version 1.1, only 5 target lesions, how to put those lesions of target lesions and non-target lesions together to define a time point response, and how to put multiple time points together for an individual patient and call it a best response for that patient. How to put the best responses of multiple patients together to come to a response rate for a treatment, and how this then defines the success of the clinical trial by comparing different treatment arms. You also know the weaknesses of RECIST version 1.1. It is not for leukemia, lymphoma, brain tumors. It has its weaknesses because it measures only one dimension, and there is a real mistake in there with it falling apart lesions that should not be followed through. You have seen an example of where RECIST version 1.1 was a gigantic success, as it was the method to come to an approval based on a study without control arm, based on response only. Now you can read the paper and the details, then memorize them, or you can use it as reference. I hope you enjoyed it. I hope we'll see you again for the next videos.